Okay. Okay, so I'll hand over to Rob and Maddie to introduce themselves in the session today.
Hi there. So like I said, yeah, I'm Rob Jones. I'm physio and team lead at South Bristol Community Hospital Stroke Rehab Unit, also known as the SARU, the Subacute Stroke Subacute Rehab Unit. Yeah, very pleased to be talking to you today about this increased muscle tone and spasticity, and then also Maddie's going to talk to you about management and treatment. I'll let Maddie do her own introductions. Go ahead, Maddie.
Hi, yeah, I'm Maddie. I'm one of the physios at South Bristol Community Hospital as well with Rob. I rotate out into the community as well. So, yeah.
Right, so I get started. Any questions, any burning questions that I could write down that to make sure we cover? You're sort of welcome to chip in as we go along. Probably the best aim is to sort of wait to the end of the session for questions. But if they're burning and they're sort of very pertinent, then by all means, we don't mind you interrupting with those questions. Anything that's sort of a burning desire that we cover today, anyone want to chip in with? I think that's 7 seconds, which they say we have to wait for to allow people to give their answers. So, right, I'll start sharing my screen. Okay, that should be visible to everybody.
Yeah, that's good, thanks.
Okay, so I'll get going. Much as I hate talking to the slides myself and not being able to see you all on screen, I'll carry on. Okay, so as we said today, we wanted to talk about understanding and managing high muscle tone and spasticity. Maddie and I have we've got different or similar but separate slide sets, so we'll transition to Maddie's in a little bit after mine. I've gone into a fair amount of detail. There's perhaps be some bits which are maybe, you know, I've sort of simplified perhaps sufficiently or too much or not enough. So please ask questions. And there's other bits that I've gone into, you know, quite a bit of detail because I think obviously there's different people on the call will want to sort of follow up with their own reading. So if there's any bits that you don't understand, please let us know. And if there's any bits you want more detail on, then we'll do what we can. And I'll get going. So what is muscle tone? We've all got muscle tone. It's basically what keeps muscles active whilst we're in different postural sets. Our muscle tone is obviously lower when we're lying. It raises as we move into sort of anti-gravity positions, sitting and standing. It's lower when we're asleep. So when our brains are sort of relatively at rest in terms of the amount of activity that they're having to do to engage with our environments. Obviously, the brain is not quiet while we're asleep, but the impact of not having to engage with the environment means that muscle tone is low when we're sleeping. What causes, certainly in the scenario of a stroke, what causes increased or high tone, or what's called hypertonicity, which is a greater resistance of muscles to passive movement. That's how we define it, and we'll get onto that in a bit more detail. But what causes changes in that in stroke is when there's a change to the neural control of the muscle, and that's what causes changes in tone. So what is spasticity? It does affect around 20 to 40%.
Sorry, your slides are not pulling through, so we're still on the first introduction slide.
Oh,
we haven't gone on.
Has that done anything there?
No, you might need to close it and then reshare.
Okay.
Everyone. Yes, there you go. What is spasticity there? That's good.
Have you got the surrounding bit around the side, which is not helpful for you to see?
It's not, but we do have the surrounding, but we do have what is spasticity there. So you have moved.
Okay, well, let's try and shrink that. That okay still?
Yeah, that's great.
Okay, well, for the sake of the last slide, no, it's not even letting me go back now. Hang on. There, for the sake of seeing what I was talking to, that's your pictures. And then what is spasticity? So it affects 20 to 40% of people who've had a stroke. The numbers vary in the literature because obviously different studies find different numbers. But we know that the damage from stroke it affects these what are called inhibitory pathways. So nerves going from the brain to the periphery, whether that's the arm, the leg, or any part of the body that might have spasticity in it. And there's a disruption to a normal sort of modulation going on. Again, I've got some slides that come up that hopefully explain that a little bit more. And that damage then causes this hyper excitability of activity sort of further down. So whether it's in the arm or the leg, down the chain, if you like, from the neural control point of view. So spasticity is, I'm struggling to move the slide along there. So spasticity, I'm just going to skip forward a couple of slides here because it helps. These different definitions help to describe it. It's a greater than normal resistance felt when moving a limb passively through range. Many sort of quite a while ago, several sort of iterations ago in terms of how spasticity has been defined. The chap in 1980 defined it as a velocity dependent increase in the stretch reflex, which means that when you move a limb through a range of movement fast, you find that the spasticity, the resistance is greater than if you move it slowly. It's just one feature, one of the positive features of a lesion in the upper motor neuron, and that's again, I've got some slides that will talk us through that. And then more recently, because I think the wording around spasticity, hypertonicity, and tone, and other words that come into kind of conversations when we talk about this become confusing. There was a consortium back in 2005 that attempted to continue to define spasticity better, and this is this idea of disordered motor control associated with upper motor neuron syndrome presenting as intermittent or sustained involuntary activation of muscles. Doesn't necessarily make it any easier to get your head around, and certainly even more recently than this last one, 2007, there are still kind of discussions about how we best define it. But what we'll just do is to skip back to what's going on. So I hope this picture comes through okay, and you can just about make out the words on it. On the left, you've got a reflex arc. This is basically how the body works, and you'll know from personal experience. You touch something painful, something hot, something sharp. What you get is without expecting to. You get a jerk reaction. There's also another example of that is that knee-jerk reaction, the classic example of the doctor in the clinic bashing your sort of patella tendon, the little bit of tendon just below your knee, and your knee jerks out. You're not able to really control that. And that's what's called a reflex arc. So the body has this protective mechanism where the sensation of whatever is going on, whether it's the tendon being hit, which sort of slightly lengthens the tendon, or your finger touching something hot, the signal from that, the nerve passes a signal that does go to the brain, but for the nerve to pass that signal all the way to the brain takes a few microseconds, which doesn't sound very much, but in terms of preserving your body function, obviously the body's developed over the years to have this much more rapid route of saving itself, which is called the reflex arc. So the nerve, as well as sending a message up to the brain, actually connects in the spinal cord. So this picture, this sort of pink cross-like shape on the right of that first picture, is your spinal cord. And in the spinal cord, there's actually an impulse that is generated that goes immediately to the nerves controlling a muscle that will bring your hand away from the painful stimulus, the painful thing, that the hot thing or the spiky thing that you've touched, or the tendon hammer that's hit your tendon. And that's called a reflex arc. And what we get with the upper motor neuron lesion, so the nerve that comes from the brain down to the spinal cord, which normally does what we call modulate that reflex activity. It calms it down and it stops it becoming overexcitable. what happens with stroke sometimes, and what leads to the spasticity developing, is that nerve gets damaged in the brain, and therefore it's not having its calming effect down at the point of the spinal cord where this reflex arc is occurring. And therefore that reflex arc gets a bit out of control, and you find that the tension in the muscle is unduly greater than it would be, and therefore your reflex arc is overexcitable. So hopefully that picture helps to explain a little bit about what's going on there. I did just want to cover this again. There's lots of writing on this slide, and it was just making sure that you're clear that again there are other things going on when damage occurs to these nerves, the nerves coming straight from the brain in this upper motor neuron lesion, and typically these are nerves in what's called the corticospinal tract. When they're damaged, spasticity is just one of many positive features, and positive features they're not always a good thing. They're called positive because they basically are changes in movement which kind of are movement producing, so they're actually causing more movement rather than less movement, but a lot of that is unwanted movement, and so we do get these brisk tendon reflexes. That's when we actually test the tendon, and we find that the reflex is greater, and some of those other things like clonus and spasms. We're not going to go too much into all of those today because we're mainly talking about the spasticity.
Rob,
just to be
sorry, just to someone's put in the chat there, and clonus is somehow related to spasticity. They've asked that question.
Yeah, it's related because it's another positive feature of the upper motor neuron lesion. So another way of saying that is when the nerves from the brain which descend to the spinal cord level to act as a calming measure to the reflex arc that I showed you in the image before, when those nerves are damaged from the stroke, then the effect that nerve has on calming everything down at the periphery, as we call it, so arms and legs particularly, where spasticity is mostly seen, is disrupted, and therefore there isn't a calming effect. And so clonus is a typical example of where we see clonus is a sort of an uncontrolled shaking of a body segment. And a classic example is the foot, when it's sort of moved into a certain part of its range, generally pulled up towards the body, and the muscles there begin to shake and the foot tremors. And that's something that is similar to, so it's connected and related to spasticity, but is a separate presentation, but caused by the same kind of thing. So sometimes you can see clonus and spasticity present at the same time. I hope that answers that one okay. I'm sorry, I can't, because I'm sharing the slides, what I can't see is the comments that come up along the way. So what I'll move on, so just let me know, won't you, if there's any more comments, questions.
Yeah, no problem. I'll keep my eye on the chat.
So moving on alongside this increased tension in the muscle, when it's been there for some time, and particularly on the unit here, we'll tend to see people following a stroke as soon as, the soonest would be a few days following the stroke. And we have people sometimes staying with us for, a few days or a week or so on the unit, or sometimes several weeks on the unit. But over that time, what we get is if someone has developed this spasticity, so the tension in the muscles, and the resistance that the muscle demonstrates to passive movement, to someone else moving that body part. When that spasticity has developed, you get some of these postures that you can see on this slide here. And if those are not sort of challenged, or if they're not, if we don't address those as a team, and that the team includes the patient themselves, sort of, and the person with stroke looking after their hand and having been told and taught how to look after the hand, but also the team here of all the nurses, carers, therapists, and support staff on the unit actually getting involved and challenging and addressing some of these problems. What we also get is a range of other problems going on alongside the increased tone. So if any of us was to hold our hand in one of those postures on the bottom there for more than a few minutes, maybe 20 minutes or so, you would undoubtedly begin to get change in sort of in the sensation of what you can feel around the muscles or the joints, and they become uncomfortable. If you were to somehow force yourself to hold that position for many hours, if not several days, then what we start to see is changing in the actual tissue of muscles, soft tissue, joints around the area that fixed or sustained posture is happening. There's this lovely word called thixotrophy, which actually talks about within collagen, which is a part of soft tissue, and the actual molecules begin to sort of stiffen up and become less fluid. So in tendons, in muscles, there are collagen, and you actually start to see the molecules stiffening up. So everything right down to the sort of molecular level starts to get stiffer if these postures are not addressed and movement is not occurring regularly. So you get changes within the muscle structure, you get a shortening of the contractile element of the muscle. You can get pain, obviously, from sustained postures. You also get patterns of behavior developing as well. So the fact that someone finds that it's hard to or impossible to move a hand because of the spasticity, they end up not using that hand regularly, and therefore there's a sort of a cyclical effect that almost means that things can get worse with the hand, because the body is, the brain is not attending to it so much, and that sort of the process that has led to the spasticity can actually continue to get worse. So really important that we address it, and I'm sure Maddie's going to go on and talk a little bit about how we do that. I just wanted to point out that there are some confounding issues with spasticity and following a stroke, whether it be related to the spasticity itself or other things going on. But what we find is that the tone in the muscle, and particularly the spasticity, can increase if there are other things going on in that person's day-to-day life which are in one way or another uncomfortable, whether that's pain either related to the spasticity or other pain. We know that shoulder pain, for example, following stroke is quite common. Other people will have, come into hospital and they would have had their stroke and on a background of having other musculoskeletal problems, back pain, for example, shoulder pain, neck pain, things that were there and have been there, perhaps the person's been suffering with or dealing with for many years. And those things are perhaps exacerbated from being in a less mobile position than they're used to after having had the stroke. So anything that causes discomfort can actually increase spasticity and cause then the sort of a cyclic effect of making things worse and worse. Other things that we perhaps see typically on the ward, on the unit here, and would be present with other people, once people with stroke go home, are things like a temperature. Everyone catches, the common cold or bugs, and the body fights those. The temperature, your body temperature, can go up as a result of that. And that's enough to actually trigger spasticity deteriorating or getting worse. And that can be temporary, or obviously if that's sustained, then that can make things worse for a longer period of time. Things like incontinence or infection in different places, whether that's a urinary infection or infection of perhaps a wound or skin damage or anything else, or a chest infection, those things can also increase the problems for spasticity. And then the other things that people sometimes have problems with are pressure areas or pressure sores from being in one position for too long. Hopefully, touch wood, those are generally a thing of the past, but we still do see them time to time, despite the best management that we can give in terms of helping people to move and move around when they're not able to move for themselves. And then the other thing would be a deficit, a problem following the stroke, which is in some way unrelated to the spasticity, which would be a change in sensation. So the part of the brain that manages sensation, let's say in the hand or the arm, if that was affected and someone's sensation was reduced or even absent, and we see that quite commonly following stroke, then that can be another reason for the spasticity itself to actually cycle and get worse, because there isn't any sort of feedback loop from the individual themselves of discomfort going on in that area, and therefore they're not as prompted to actually go and do anything about it themselves.
Rob, someone's just asked here that why does spasticity increase a UTI? So I guess increase the possibility of a UTI.
Okay, sorry, perhaps didn't make that very clear. It's the other way round. It's not, you would not expect that spasticity would increase the risk of a UTI. What you would expect is that a UTI, a urinary tract infection, could very much is likely to and very often would increase the spasticity itself and the impact of that spasticity. So someone's hand that was maybe sort of resting with some increased tension in the muscle and needed a bit of stretching to sort of manage it, then gets a UTI, probably will have a raise in their body temperature as the white cells, the blood cells, sort of do their inflammatory thing and try to sort of rid the body of that infection. The temperature goes up, there's an infection there, and then you would find that the spasticity and the impact of that, so the tension within the hand, the ability to get the hand stretched out, for example, would become greater and more difficult to manage. Until then, that infection passes, or if it's treated with antibiotics, improves, and then actually that's something that's reversible, and the spasticity can go back to its kind of baseline level. On the other hand, some of on the previous slide, I was talking about some of those other changes, the changes in soft tissue around the areas. If that infection has been sustained, then you actually might find that the level of spasticity and tone remains increased even after that infection passes. And then the other thing I just wanted to mention was this concept of sort of body image as what I mean by that is the people's body image can be affected by stroke. So actually awareness of your body and where things are is quite a commonly reported issue following stroke. And actually, if your awareness and your sort of what we call body schema, the representation of your body in your own brain, is affected, then that can be another thing that can implicate or exacerbate the problems of spasticity. And then I mentioned on the previous slide this idea about soft tissue changes, and actually we get contractures. Now, contracture itself is purely the change that is going on within the tissue at a particular area. So the picture of the hand on the bottom of this page, that will have contracture within the soft tissues of the muscles and tendons that go to the fingers, and the soft tissue within the palm and the hand itself. Has probably been as a result of the spasticity, but it is separate as an issue from the spasticity. And it's important that we kind of deal with those separately as well. And Maddie's going to get on to some of that, I'm sure. Okay, so finally, I just wanted to talk about assessments. We have a range of different ways of assessing spasticity and muscle tone. You can see there the modified Ashworth scale that is just one of several different kind of recognized and validated tests that we use, and it gives us a score, a measure, an outcome that we can actually keep track of. So we tend to do that early on in someone's stay, and then we can repeat that at intervals so that we can kind of monitor change within spasticity. We'll also look at PROM, which is passive range of movement within a joint, and sometimes those assessments sort of look very similar to each other, but we're just looking at slightly different things. You can see the image in the top right there is someone with what's called a goniometer, so measuring a joint, that's wrist extension. The thing that the lady there has got strapped to her wrist is I think they're called inclinometers, but they basically measure range of movement kind of electronically, and I think that picture is part of a study where they're comparing how accurate those digital measures of range of movement are. We'll also look at strength, obviously, within the area, and we know that spastic muscles, although they look like they're very busy and very tight, and they're causing these really debilitating postures, actually the muscles themselves can become weak. So although they're very active, the muscle itself can be weak. And so it's really important, particularly as physios, that we remember that to actually do something about that, and to actually strengthen those muscles, as well as strengthening the muscles which oppose those postures. We look at pain, we assess pain in a variety of different ways. We primarily want to know what people's function is like. So how people are managing to get on with their day-to-day activities essentially comes, is the key part of any of our assessment. And then resting postures and comfort as well. So briefly, just to summarize then, it's really important that we pick out, we try and understand what the triggers are for spasticity, or for changing and deteriorating spasticity. It's really clear that our input looks at goals of treatment, and that needs to be with the individual themselves. We'll look at physical management, medication, and botulinum toxin, which Maddie, I'm sure, will go on to talk about. And there's that kind of comment on the side there, is that sometimes the spasticity can be the symptom of another presentation. So there can be pain causing certainly a reduction, an increase in spasticity, and therefore it's the pain that we need to sort out and find that the spasticity then improves. I think that's me done, Maddie. Over to you. Yeah. So I'll stop sharing.
Right, try and share mine. Can you see that one?
Yeah.
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 And then you can see that?
Yeah, that's good.
Lovely. Okay. So yes, I'm going to talk about the management of spasticity and how we tend to do that. As Rob kind of went into, why does spasticity need to be managed? So as he said, spasticity can lead to muscle shortening, those contractures, joint deformity, and altered biomechanics. So for patients, this can result in pain, reduced function, increased falls risk, reduced independence, increased care need, difficulty with maintaining hygiene, pressure sores, infections, increased days in hospital, and can sometimes lead to mortality as well. So it's really important that we try and identify management before we get sort of down this chain of things that can impact patients. Should we always treat spasticity? So unfortunately, spasticity cannot be cured, but it can be managed. There is no kind of gold standard of how we should manage it. The management is very patient specific and goal orientated. It's not always not all spasticity requires treatment. So intervention should be offered only where it is likely to have a meaningful benefit for the patient. And this is set in all the guidelines that we follow from the RCP and the NICE guidelines as well. So spasticity should be treated when it is causing symptoms like pain or problems for the patient's function or care provision. The presentation, the presence of spasticity does not always mean that the underlying muscle is strong. So for some patients, their spasticity actually aids their ability to function. So it helps them with standing and walking, or they can use their arm with spasticity to hold objects. Whereas if we completely took that spasticity away, they'd have a really flaccid limb that they wouldn't be able to use in function. If the spasticity, was completely removed, it may stop them to complete their functional tasks. So when we're treating patients, we really need to consider it's a bit of a balancing act between the treatment that we're doing and the function that the patient has, and really consider that before we treat. So what are we trying to achieve from our treatment for them? So therapeutic treatments. So what we aim to do is try to explain the spasticity to the patient. So from Rob's explanation, you can tell it's really complicated. So trying to explain that to patients can take a few times to kind of explain it. And sometimes you might say it one way and it's hard to understand, and you kind of come back and you say it a different way. But it's really important that they understand kind of a form of what it is and why it's something that we need to manage, and what the risks are for the future, to try and prevent the contractures and kind of get them on board with the management early, so that they kind of prevent those contractures, and then we have to treat that in the future. As Rob kind of said around the triggers that worsen spasticity, so if the patient, or you're feeling anxious, you've got a fear of falling, you're in an uncomfortable position in a chair, or you've got uncomfortable clothing, constipation, incontinence, and pain. So I can't see under the these can all increase your spasticity and your tone. So it's really important that we explain this to people, so that they can kind of monitor their own triggers. So what I try is trying to get patients to report back to me on sessions around, okay, I'm feeling a bit more anxious today, so I know that my spasticity might be a little bit worse, or I've had an infection, or so actually my walking might not be so good today, or just so that they're kind of a little bit more aware of ups and downs, and that not everything it's not always going to be up, it's going to be a bad day, good day, and it might be based on these external triggers and factors that are impacting on the spasticity. So what we do in our treatment and management is around them self-managing their triggers, and also their self-management of doing the exercises daily and regularly, to prevent any of the contractures and the worsening side effects of the spasticity from happening. So some of our main treatments that we use, so we do weight-bearing exercises. So this helps to activate the anti-gravity muscles, helps with sort of normal movement patterns, grounding effect on muscles, so then they're used to being upright, and provides a stretch to the muscles as well. And then strengthening exercises, so as Rob said as well, that the underlying muscles are often weak underneath the spasticity. So what we aim to do is the muscle with spasticity. What we can do is, by strengthening, we can also allow the brain to understand when to kind of turn the muscle on, but also off again. And that can be really effective to try and calm down a bit of the spasticity as well. And then for the opposite muscle, so the muscle that's doing the opposite effect of the muscle with spasticity, you can, by strengthening that muscle, you can help to reduce the muscle with spasticity's effect by having a stronger counter effect on the muscle. But with strengthening, it's worth bearing in mind that not every patient has the activity there after a stroke to be able to strengthen as well. So splinting as well we use. So this helps to prevent loss of range of movement, and then prevent worsening contractures. So it helps to maintain range of movement, and sometimes you can slowly increase the specific splints, increase the range of movement to allow for a prolonged stretch. Stretches help maintain muscle length and range of movement, and we can set patients up with doing these daily with themselves or with their family, so that they can maintain their range of movement. Positioning, so we kind of focus on early identification of poor positioning. So this is kind of, are you noticing that you're having your hand on your lap a lot of the time, or that your legs are kind of, your knees are together and kind of on one side in a windswept position? So as physios, we try and identify these things really early to avoid them becoming kind of a habit in positioning, and then getting contractures from sort of maintaining the same position for a long period of time. And then what we use is positioning to kind of counteract any contractures that you've got. So for example, the picture is like a T-roll. So if you've got your knees that are together and they're getting quite stuck from contractures, then you can use bits of equipment to kind of help to improve a patient's positioning and to reduce that contracture as well. And then self-management and education, as I said, around triggers and completing their own exercises. And physios and OTs can help to kind of guide patients on how to do this themselves. So we can set them up to do to do them daily, so that they don't always need us there with them. Okay. And then pharmacological treatments. So as Rob kind of said as well, around, just want to say, with sort of pain management, so we'd look at sort of pain medication as well, and kind of the other managements for antibiotics, things like that, as a pharmacological treatment, but I won't go into that too much detail. So one of the main ones is baclofen, so it's used for generalized spasticity. So baclofen is a pill that is taken sort of every 2 to 4 hours, and reduces the release of the excitatory neurotransmitters. It works globally to lower muscle tone throughout the body. It takes away movement and will not add movement. It needs to be used in conjunction with the therapeutic treatments that I've mentioned, so to gain function and to prevent loss of range of movement. It may not work for some people who rely on the spasticity for function. So because it works globally, it can reduce your tone and your spasticity everywhere. So if you really rely on the spasticity to help you with certain functional tasks, it might not work for those patients. Also, the fact that you have to take it quite a lot throughout the day, some people might not be able to take that much medication or might need support with that. So it's something to bear in mind. And then the BNF states that the side effects of baclofen can include confusion, constipation, headaches, and drowsiness. And a lot of patients that I've seen really struggle with the drowsiness of the baclofen. So then they don't want to take it because of that. So it's kind of a bit of a weighing up the pros and cons of taking it versus some of the side effects that you might get. And it needs to be kind of titrated. So you start on 15 milligrams and then build it up. So it's a bit of a balancing act again of sort of how much for patients to take, and is that making a difference for them? And you can't just stop completely, you have to kind of wean yourself off. So if you are feeling really drowsy, it can take a bit of time to kind of wean off the baclofen as well. So yeah, as I said, it takes away movement. So it's not something that is going to add movement. So it will reduce the muscle contraction spasticity, but then it's to use in conjunction with the therapeutic treatments to kind of try and improve the range of movement or prevent the loss of range of movement as well. And then Botox. So that Botox is used for focal spasticity mainly. So it's an injection that can be given by trained staff and usually in a clinic setting. It can target specific areas and muscle groups, meaning it doesn't have an effect on other areas of the body. So it's effective for patients that may, as I said, need their spasticity in their function, and it can be targeted for really specific muscle groups. It works by blocking the presynapse to stop muscle contractions. Therefore, it takes away movement and again does not add movement. So it's really important that patients are set up with their therapeutic treatments and understand that it's a lot of work and stretches and exercises and things after this injection, so to get the most benefit out of having the injection. Its clinical effects are temporary, so it lasts about 3 to 4 months, and then you can go back to clinic, and then they'll ask in clinic, how did it how did it go? Is it worth doing another round? Or should they change the muscle groups to inject in that session? The adverse effects of Botox can obviously be local muscle weakness. Flu-like symptoms are kind of the main ones, and in very, very rare cases can cause dysphagia. Yeah, and then there's other treatments which are kind of from really severe spasticity, sort of nerve blocks, and you can refer for orthopedic surgery to have tendon and muscle lengthening, but that's kind of in really severe cases, and you need consultant and support for that referrals. Okay.
Great, thanks, Maddie. I'm just going to stop the recording before I open up for questions.